Hello, I'm Roger Henderson and I co-host the GPnotebook study groups. Welcome again to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, I'll be discussing Barrett's esophagus, what it is, why it matters, and how evolving evidence is changing the way we diagnose, monitor, and manage this condition. And this is a topic that most of us encounter frequently in practice, and yet it continues to evolve. So let's start by setting the stage here. Barrett's esophagus, and I'm probably just going to call it Barrett's for this podcast, is best understood as a pre-malignant complication of chronic gastroesophageal reflux disease, or GORD. Endoscopically, it appears as salmon-coloured mucosa extending at least 1 centimetre above the gastroesophageal junction, replacing what should be normally pale squamous epithelium. And histologically, this area shows columnar epithelium with goblet cells, which is the hallmark of intestinal metaplasia. Now, while Barrett's itself is not cancer, and that's a really important point, it represents the only known visible precursor lesion for esophageal adenocarcinoma, a malignancy with high morbidity and mortality that has been steadily increasing in incidence over the past several decades. And that fact alone is why Barrett's has drawn so much attention and why surveillance and treatment strategies continue to be refined. Now, most cases of Barrett's are acquired rather than inherited, and the usual precipitating factor is long-standing gastroesophageal reflux disease. Chronic exposure of the distal esophagus to gastric acid and bile salts leads to repeated epithelial injury, and unfortunately, the squamous lining of our esophagus simply isn't designed to tolerate that environment. Over time, inflammation becomes persistent and the tissue adapts by transforming into a columnar phenotype better suited to acid exposure. And eventually, that columnar epithelium can undergo intestinal differentiation, complete with goblet cells. Now, interestingly, only a minority of patients with reflux develop Barrett's. An estimate suggests that up to 15% of patients with chronic reflux symptoms may develop it, and around 1% of the global population has it, with about 0.5% of patients with Barrett's proceeding to an esophageal adenocarcinoma. And that raises an important question. Why do some patients develop Barrett's and not others? Well, unfortunately, we still don't have a complete answer, but we do have a fairly well-established risk profile. So Barrett's is more common in men, particularly non-Hispanic white men, and the risk increases with age, especially after the age of 50. And central obesity plays a significant role, likely due to increased intra-abdominal pressure and metabolic factors. And we also know that smoking, either past or present, is another contributor. A family history here matters too, as there's a recognised familial Barrett's phenotype, likely to be inherited in an autosomal dominant pattern, though specific susceptibility genes haven't yet been definitively identified. But the bottom line here, though, is it seems that for Barrett's to develop, environmental factors must interact with genetically determined characteristics. Now, despite all this, I think it's important to keep a sense of perspective here, as the vast majority of patients with Barrett's will never develop cancer. The risk of developing it increases substantially when dysplasia is present, particularly high-grade dysplasia, which carries a much higher short-term risk of malignant transformation. And understanding that progression brings us naturally to pathophysiology. So at a molecular level, Barrett's is driven by chronic inflammation and genetic instability. Acid and bile exposure stimulate inflammatory cytokines, including interleukins that recruit immune cells and perpetuate tissue injury. And bile acids in particular appear to play a role in intestinal differentiation by activating transcription factors such as CDX2, which is essential for intestinal epithelial identity. There's also some ongoing debate about the cell of origin for Barrett's. Some evidence points to stem cells located at the squamo-columnar junction, while other studies suggest contributions from mesenchymal or even bone marrow-derived stem cells. But what's clear is that the metaplastic process likely proceeds through intermediate stages, including a so-called multi-layered epithelium that exhibits features of both squamous and columnar tissue. Now, histologically, the diagnosis hinges on identifying intestinal type columnar epithelium with goblet cells replacing the normal squamous lining. Non-dysplastic Barrett mucosa may show some nuclear changes at the base of the glands, but the surface epithelium remains mature. Now, when dysplasia is present, this is categorized as indefinite, low grade, or high grade. So indefinite dysplasia is essentially a grey zone, often confounded by simple inflammation or regenerative changes. Low-grade dysplasia is characterized by nuclear elongation, stratification limited to the lower half of the epithelium, and increased mitotic activity that remains largely confined to the crypts. High-grade dysplasia represents a much more disordered architecture with full-thickness nuclear stratification, loss of polarity, marked pleomorphism, and mitoses extending to the surface. Now, once malignant cells invade the lamina propria without breaching the submucosa, the diagnosis becomes one of an intramucosal carcinoma. And distinguishing a high-grade dysplasia from an early cancer can be challenging, and it's associated with significant inter-observer variability, which is why expert pathology review is so strongly emphasized in our current guidelines. So clinically, most patients with Barrett's present with symptoms of GORD, heartburn, regurgitation, and even sometimes dysphagia. But others may have atypical symptoms such as a chronic cough, hoarseness, or chest discomfort. A significant subset, though, is asymptomatic, and this complicates detection and reinforces the importance of risk-based screening. Now, Barrett's is a histological diagnosis, and so endoscopy with mucosal biopsy is the gold standard here that's required to establish this diagnosis, because the physical examination is almost always normal. Endoscopically, there must be at least 1 centimetre of columnar appearing mucosa above the gastric folds. And to improve detection, high definition white light endoscopy is now usually standard, and chromoendoscopy, which is either dye-based or electronic, can also now enhance the visualization of subtle lesions. But newer adjunctive tools are currently being studied. So wide area transepithelial sampling, sometimes known as Watts 3D, uses a brush to sample a broader area and deeper layers of mucosa. Now, whilst this may improve detection of dysplasia in some settings, it still doesn't replace traditional biopsies. Artificial intelligence is also now being explored to assist endoscopists in identifying suspicious areas in real time. But the bottom line here, how do we manage Barrett's once it's diagnosed? And the keystone here is good old-fashioned acid suppression. All patients with Barrett's should be on long-term proton pump inhibitor therapy, even if they don't have active reflux symptoms, as the evidence suggests that PPIs reduce the risk of progression to neoplasia, probably by decreasing acid exposure and subsequent inflammation. Surveillance intervals depend on the presence and the degree of any dysplasia. So for non-dysplastic Barrett's, surveillance endoscopy is recommended every 3 to 5 years, with shorter intervals for longer Barrett segments. Indefinite dysplasia warrants optimization of acid suppression and repeat endoscopy within 6 months. Low-grade dysplasia, however, represents a turning point. While surveillance alone is an option, endoscopic eradication therapy is becoming increasingly now favoured, given the substantial risk of progression and the effectiveness of modern endoscopic treatments. High-grade dysplasia and intramucosal carcinomas are clear indications for endoscopic eradication therapy in most patients. So what do I mean by endoscopic eradication therapy? Well, this typically involves a combination of resection and ablation. Visible lesions are removed using endoscopic mucosal resection or, in selective cases, endoscopic submucosal dissection. The remaining Barrett's mucosa is then ablated, most commonly using radiofrequency ablation. But other modalities such as cryotherapy or hybrid argon plasma coagulation can be used in specific scenarios. Now, these approaches have largely replaced esophagectomy as first-line therapy for most patients with dysplastic Barrett's or early cancers, dramatically reducing morbidity whilst maintaining excellent oncological outcomes in appropriately selected patients. But even after complete eradication of intestinal metaplasia, though, surveillance doesn't stop because recurrence can occur, most often near the gastroesophageal junction, so ongoing endoscopic monitoring still remains essential. If we look at prognosis, Barrett's carries a generally favourable outlook when it's managed appropriately. Most patients, as I say, will never develop cancer, and those who do are increasingly being identified at an early and treatable stage. Advances in endoscopic therapy have transformed what was once a surgically dominated field into one where minimally invasive, organ-preserving treatments are becoming the norm. If we look specifically at numbers, the risk of progression to esophageal cancer after 5 years is 2.7% for people with non-dysplastic Barrett's, 6.6% for people with a low-grade dysplasia, and up to 30% for people with a high-grade dysplasia. So before I wrap up this, I think it's worth touching on prevention and patient education, as this is really important and lifestyle modification really does matter here. Smoking cessation should be absolute and weight loss should be strongly advised, with dietary recommendations mirroring those for GORD, such as limiting fatty foods, alcohol, caffeine, and eating late. Now, whilst diet alone won't reverse Barrett's, these measures can significantly improve reflux control and overall health. So just to bring all this together now, Barrett's is a common and clinically significant consequence of chronic reflux, with a well-defined but relatively low risk of malignant progression for most patients. Thoughtful screening, accurate diagnosis, risk-based surveillance, and timely endoscopic therapies have all now dramatically improved outcomes. And as biomarkers, artificial intelligence, and endoscopic technology continues to evolve, our ability to personalize care for these patients will only continue to improve. So that's a quick overview of Barrett's, and I do hope you found this podcast helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free GP shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.